Today's session is on artificial intelligence in medical practice and healthcare standards in Nigeria and also across the African continent. It's going to be an amazing and impactful session. This session is curated for the health system, leaders, and all the earth sector professionals generally, and also for medical professionals, particularly because it's been hosted by the Nigerian Medical Association on positioning to influence the adoption trajectory of artificial intelligence in the Nigerian healthcare system. While we await the leadership of the NMA, we would start for a want of time. Please, I like the introductions coming. You're welcome, Professor Idris Sule. It's a pleasure to have you. We might not be able to spotlight all the introductions going on in the chat, but we see you. Thank you very much, Dr. Olukemi Akumusere. Thank you very much, Dr. Abdulwahab Etu. We see everyone in the room. As more people join, please feel free to drop your introductions in the chat. So today we have a privilege to have with us amazing experts in this field. And I'm not, just wasting words by saying amazing experts in this field. They are sought after people in the area of artificial intelligence and health globally. And then we'll introduce them as we go in. If Professor Bala Adu is here as representative, it would be an honor to yield to the Nigerian Medical Association for the welcome remarks. Or if Dr. Hamid is here, we would have him, take over the introductions, and then we can go into the presentations quickly because of time. Thank you, Professor Bashino. We see you. You're welcome, sir. And we're happy to have you here. All right. Thank you very much for joining. I'm sure this session will be one of the impactful milestones that we need to take in our journey and trajectory for establishing the right standards, the right frameworks for artificial intelligence in medical practice and healthcare standards. So, Dr. Hamid is not here yet. I guess he's really
Dr.
trying.
Hamid is here. Good afternoon,
Dr. Hamid,
everyone.
You have made me talk for the longest time possible. Let's get started with the welcome remarks from NMA. Dr. Hamid is the country rep or the lead for the Doctors Medical Aid Foundation, an affiliate non-governmental organization of the Nigerian Medical Association. Over to you, Dr. Hamid, and we need to move faster because of time.
All right, thank you very much, Dr. Kunle Kakanfo. It's a pleasure being here. The Nigerian Medical Association is happy to be a part of this process, the process leading to having healthcare standards in Nigerian medical practice with the reckoning of artificial intelligence as a necessary tool, as what we have to live by, as an advancement that has come to stay in the global space. As have been rightly introduced on Dr. Hamid Adedira, I'm the country director for Doctors Medical Aid Foundation, but I double as the chairman of the National Committee on Information, Communication and Technology and Corporate Affairs for the Nigerian Medical Association. So without wasting so much of our time, I'd like to welcome you all on behalf of the president of the Nigerian Medical Association, Professor Bala Audu, who is currently away and due to time zone differences, may not be able to join us. Other members of the National Officers Committee will be joining shortly and will be taking the closing remarks as required. So let me just hand over back to Dr. Kunle to take it further from there. Thank you, and please permit me to particularly appreciate our keynote speaker, one of our very own ambassadors that we're very proud of, Professor Itope Ogunbodede. Thank you for accepting to be a part of this with us. And Professor Jude Kong, thank you for this as well. Over.
All right, thank you very much, Dr. Hamid, and thank you for that initial remarks, and sure we'll be getting more remarks from the NMA leadership as we go on. And we'll just get straight into it. Like I said, this session is a defining moment also for us in the healthcare space, and also for those of us in the clinical practice, and also in the Nigerian healthcare sector in terms of artificial intelligence So we would make the best of it. Next slide would show us how we intend to navigate today in terms of the agenda. Because of time, we'll be crunching between the two keynote because Professor Jude Kong would have to step aside earlier. But we will quickly get started with Professor Eyitope Ogunbodade. Professor Eyitope Ogunbodade is not. You need to go to the next slide. I will struggle to introduce you, sir, but I'll do my best and keep it very short. Among his many accolades, he was the former vice chancellor of the Obafemi Awolowo University, Ile-Ife, and I think that should say, if not everything, that should say enough about the caliber and the kind of domain expertise that it's being brought here. And he's also the president of the National Association of Artificial Intelligence Practitioners, which he will be talking a little bit more about. So Professor Eyitope Ogunbodade will be talking to us today about the AI imperative for medicine in Nigeria. And I would yield over to Prof. Prof, apologies that I kept your citation short. It's for want of time. I'll yield over to Prof to get us started in today's session. As part of the session norms would be, please drop your name and what you do right in the chat, and we're happy to spotlight as we go on. And if you have questions as we go on, also please drop them in the chat. At the back office of this Zoom call, we'll take your questions. I will definitely make sure your questions are responded to. Thank you very much. I will welcome you at this stage, Prof, for your keynote before we go right into the other parts of the session. Thank you. You're welcome,
Okay.
Prof.
Can you please permit me to share my slide? I will briefly be talking about artificial intelligence in medical practice and the healthcare standards that are actually required. I need to start by recognizing our distinguished colleagues, but because of the time, let me just recognize Dr. Hamid Adediran and all members of the NMA that are here, then Dr. Kakanfo for inviting me to give this presentation, and then other keynote speakers, Professor Jude Kong, my colleagues that are here, and then Professor Bala Audu. Thank you very much. So the history of artificial intelligence is very interesting, but what exactly is artificial intelligence? I will just limit myself to the one definition, which is a machine possessing intelligent capabilities, learning, communication, information processing, and induction that can perform or aid humans in performing human functions. In essence, artificial intelligence is something that human beings can do, but which is now being performed by machines. So, and this was actually popularized by John McCarthy in 1955. So this is just to talk about a lot of transformative technologies shaping medical education and practice. So it's not just artificial intelligence, but there are so many others. And this is just depicting, some of the transformative technologies. So the three tiers of artificial intelligence: narrow AI, generative AI, and then artificial general intelligence. But these are things that are very common that I am aware of the fact that you all know this. So what is very important and what is key that I want us to take away is that AI presents immense opportunities for transforming the Nigerian healthcare system. Quite a number of people are yet to imbibe, the fact that AI is here to stay and we cannot run away from it, and is dictating almost every aspect of our practice, of our lives, even as we speak today. So, and I think this is one thing that is important. However, the integration must be ethical, it must be inclusive, and it must be context sensitive. We just cannot adopt any type of AI in the healthcare field. So what is the current status of AI in medical education and practice? So we discovered that, as we are today, so there is a rapid adoption of AI, and then there is the impact, which is actually affecting every aspect in medical education and practice. But one common thing that I want to emphasize, to our audience here and our colleagues, is that within the medical education system, the students are actually far ahead of the lecturers, and that speaks volumes. But what we are trying to do now is to ensure that at least the lecturers imbibe that culture and that they move as fast as possible to ensure that there is a balance, in the medical education system. But in terms of practice, the equipments that are actually coming in, they are compelling people even to ensure that they are familiar with artificial intelligence. So AI extends the clinician, it does not replace the clinician. And that is one thing that we must realize. And in several areas, rheumatology, endocrinology, orthopedics, physiotherapy, radiotherapy, in almost every area of medical practice, AI is actually shaping clinical care. And in what way is it shaping clinical care? Now, the old way of practicing things no longer work in the present day because, what you are using now is no longer what it used to be. And that gives a semblance of what is even going to come in the future. So now, I have actually put in this to let us know where things are going. And so there is the Neural Link project, which I think we should all be, familiar with. And what this is trying to do is an American neurotechnology company that co-founded by Elon Musk in 2016 that is actually developing this. And is a small cosmetically included implant is placed in the region of the brain that plans movements. So, and everything, the technology, everything is done by robots. And it's such that once it is implanted, the patient will be able to control, the computers and do everything. So when you have hemiplegia and all those other things, then they help the patients to be able to maneuver and do several things. And this is not a futuristic thing. It's something that had actually been concluded. And so if you Google Neural Link project, you will see everything about that there. The vision of the Neural Link project is to change lives, and that they have successfully done. In fact, they have done that for about 4 patients, and it's actually working. Even though after some years, they found that it could become loose and they need to do it again. So, but they have done that successfully. And so if you can implant something in the brain of a human being and it can then control so many things even without making any movement, then we know exactly where AI is taking medical practice to. The other example that I want to give is the Brain Bridge project, where this is also supported by Elon Musk, where they are now trying to do a head transplant, a total head transplant. What they are saying is that this is possible. So head transplant is not new, but it's something that people have tried over decades. But now they are saying with robotic surgery, now it is possible to transplant the total head. So for one human being and then transplant the head of somebody to the body of another human being. And that already is in the final stage. And that is the Brain Bridge project, which this is just an extreme of some of the things that are actually going on now. So what they are claiming is that this is purely ethical and that is something that they thought about and they are very convinced that it is the way to go. Key concepts of the procedure is that it gives a new lease on life, and then that it's robotic and AI enabled, and then that when you do this, so it could you can do surgery even at the molecular level. Okay, so let me skip the brief history of head transplantation just to say that it started right in 1908. So the rise of AI in medical education, why does it matter? It matters because integration of AI in medical education has become mainstream due to its ability to improve and simplify the learning process. Okay, let me talk about the advantages of AI in medical education. So there is objective student assessment, better clinical simulation, better time utilization, individualized training, enhanced education, and then transparency too. Okay, advantages of AI in clinical settings. It gives stress-free training environment, round-the-clock learning, remote learning and telemedicine, individualized feedback. These are things that we already have before, but now with AI, they are actually enhanced. What are the challenges arising from the growing use of AI in medical practice? So we need to acknowledge that there are challenges, and those challenges need to be addressed to prevent potential benefits from becoming serious risks. One of the challenges in Nigeria is the internet penetration. We can see on this slide that Nigeria has very low internet penetration as of today, 55%. And that is not something that is really favorable, because if you want to cover the whole of Nigeria, you find that only 50% has an internet penetration. That is something to worry about. So the barriers to adoption in medical practice, they are quite numerous, but some of these are ethical and legal challenges, the scalability limitations, evaluation, the difficulty in evaluation. Then there are no guidelines and standards for now, and that is why this kind of webinar is important, to develop guidelines, standards, and policies, and NMA is well positioned to be able to champion that kind of initiative. And there is also the issue of job displacement and reskilling. Yes, AI is not going to take jobs, but people have to reskill to be able to continue to do what they have been doing before. So what are the solutions to the challenges? Clear policies and guidelines, regular evaluation, regular training and reskilling, and then there should be collaboration. So that's why I'm happy that NMA is collaborating, with this group. And then NAIP, the National Association of Artificial Intelligence Practitioners, of which I'm the president, is also ready, to collaborate. And then the MDCN and the NUC must also be brought on board. So integration of AI in the Nigerian university system, the NUC has actually set up a committee, and we have submitted, and it has been passed on to all Nigerian universities. One key issue there is that every Nigerian university will now have an elective, which all students in the university will be exposed, that will enable them to understand what AI is all about and how they can utilize it for maximum benefit. And so these are the members of the committee, which I chaired on behalf of the National Universities Commission. So 3 principles for AI in medical education: foundational literacy, quantitative foundations, and then the key thing there is the ethical use of AI. Requirements for effective integration of AI in medical education. What are the requirements? You need to train staff in AI. Like I told you, students are far ahead of staff now in most medical educational institutions in Nigeria. Developing appropriate curricula, which needed to be done. Now we have the elective developed for Nigerian university, providing AI infrastructure, interdisciplinary approach, and then appropriate assessment methods, because the old methods of assessment is no longer viable now. When you ask questions now, before the next person, they already have Googled it, or they have used ChatGPT, and they already have the answer. So the assessment methods need to be different. Enhance data security and protection, addressing ethical challenges, and then monitoring, evaluation, and other issues. Okay, so what are the future developments? How will the profession, how the profession will change? One is that application of artificial intelligence has come to stay, and then there is no way we can change that again. And then there will be increasing use of remote consultation and treatment. When a procedure is taking place in another country, students in a different country can be watching it, and they can be part of whatever is going on there. And then there is also the ability now to gather information from multiple data sources. There is also the issue of adept in machine interface handling. And then skills are also now available to leverage the benefits of AI technology. But people have to be trained. And that is why I want to emphasize NMA must take the lead to ensure that there is reskilling. And then there is also AI being complementary other than replacing the traditional kind of way of doing things before. There should be training in order for people to be able to utilize that. Now, I just want to let us know that we have a school in the US now, the Alpha Private School in Austin, Texas, where there are no teachers. So you only have guides. And that is the future of education. So no conventional teachers. And then very recently, too, we find that in September 2025, Albania made headlines by appointing AI called Diela as minister. Albania is now the first country in the world to appoint AI-operated person as the minister. And then why did they do that? They did that because they feel that human beings have some emotional bias and everything, and they wanted somebody or something that will be true to type and that will not be influenced by human emotion and the other the rest of it. AI is not a substitute for human judgment. I think we must go away with that. So yes, AI is a powerful tool, but it's not a substitute for human judgment. And the future of healthcare lies not in machines replacing doctors, but in doctors leveraging AI to enhance diagnosis, treatment, and patient care. The goal is a synergistic partnership where human oversight and technological innovation work together to improve outcomes. And then AI must be used responsibly. AI has the potential to augment human capabilities, not replace them. While I'm concluding, I want us to understand that it will be tough for medical training institutions and the profession. And NMA must know that if artificial intelligence is changing the world so rapidly and the medical fraternity refuses to change, then it's going to be tough. So we need to be in the lead. And I want to say that the National Association of Artificial Intelligence Practitioners, we are ready also to work with every organization, and particularly Dr. Kunle Kakanfo that has approached us, and then we have had some discussions. The NMA working with you and your group is something that I think is very positive, and that which is fully supported by anybody who is a medical practitioner in this country. All that is left for me is to thank you for giving me this opportunity, and to thank the organizers for coming up with this very important webinar. So this is a way to go, and thank you for pioneering this. Thank you very much, and thank you for the opportunity.
Thank you very much, Prof. One of the reasons why I find this outstanding and really shows that we'll have a very deep root in our AI trajectory in the healthcare system in Nigeria is that when you see a cross-generational leadership from Prof, taking the lead as the president and national chairman of the Nigerian Association of AI Practitioners, it shows that we're ready as a people in terms of talent. We have the potential to get the right skilling. And thank you very much, Prof. It's an honor. And I know this slide is loaded. Prof, don't worry. We will do a proper masterclass on AI in health in the days to come. So we can.
Thank you very much. Thank you for the opportunity.
Thank you very much, Prof. It's a pleasure, sir. We would, before we go to the next session with Professor Jude Kong, I just want to make sure that Professor Jude Kong is ready, but it's just that it's also, Professor Jude Kong also advises the Canadian government on AI in health and a range of other issues related to AI. So he's currently in the Canadian Parliament House. So I'm just trying to give him time to also come up and be able to give us some awesome. Professor Jude Kong is right there. All right, so Prof, before we go to you, I quickly just want to acknowledge one of our mothers in the house. She's the national president of the Medical Women Association of Nigeria. We definitely had an encounter recently. Our energy, our depth, strategic leadership on AI and this thing. She sat with us for 2 days learning AI, and it was impressive how much of the members of the association that she brought into those sessions. So if you're on the call, Dr. Zainab Kwaru Mohammed Idris, please would like to just hear you say hello to us. This is me saying that I've missed you, ma. So if you can come up to just say hello to us, if you're on the call. I think I saw you a little while ago on the session. Dr. Zainab, if you're there, ma. She's also a board member of the Doctors Medical Aid Foundation. All right, so while we can, so it's thank you very much, Prof. So questions can come in. We will take those questions after Professor Jude Kong, because Professor Jude Kong needs to exit to another meeting also. Professor Gubodade is still with us. So I'll yield to you, Professor Jude Kong, and thank you very much for joining us. Professor Jude Kong is a professor of the School of Public Health, Dalamala School of Public Health in the University of Toronto. He is also the Executive Director and a Professor Real Lead for the Artificial Intelligence Center of the University of Toronto. He is also graced us to be one of our very trusted partners and support. They provide us significant technical support and assistance in our program. And it's an honor to have Prof on the call and in this session. Over to you, Professor Jude Kong.
Thank you for this opportunity to come here and be able to have a conversation with you, with this board, about AI in clinical practices and health systems. I hope we had enough time, but I'm looking forward to us building on this. So I would like to acknowledge the funders of the work that I do. This includes the International Development Research Center of Canada, UK International Development Office, CIDAM, National Research Engineering Research Council of Canada, New Frontiers in Research Fund that have supported the work that we do. Again, I must say Nigeria always lead as a leading country in the continent. And I'm really glad that the Nigerian Medical Association is looking at the standard. When Prof spoke earlier on and talk about the standard, talk about capacity building, which is what we need to be looking at the moment. I was really very impressed. I really want to acknowledge the Doctors Medical Foundation, as well as my very good friend and a leader, somebody I respect so much, who is doing a lot in building capacity in the continent and in Nigeria. Dr. Kakanfo, thank you for what you do, sir. We are behind you and will support you in whatever way possible. Very grateful. Like Prof said, I'm a Canada research chair at the Delaware School of Public Health, where I lead the Artificial Intelligence and Mathematical Modeling Lab. I'm equally the executive director of the Global South Artificial Intelligence for Pandemic and Epidemic Preparedness and Response Network. We are in 23 different countries. At the moment, we're in 10 countries in the continent, including Nigeria. We have built point-of-care technologies, and several other technologies are currently being used by government and hospitals across the world. With due time, we'll be able to share some of those solutions to the students. As I was asked to give this talk this morning, and I was looking at the Oxford Artificial Intelligence Index for this year, I couldn't really take my eyes but look at the exponential growth in which the number of AI medical devices that have been approved by the FDA are growing from 1995 to 2025, very exponentially. And if you look at it, by 2017 we're nowhere, and then exponentially it grows just within a short period of time. If you look at it this way, as I look at that, I realize that most of those companies are based, if you look at the companies that have those medical tools, devices that have been approved, they are mainly based out of the US. These are the companies here in China. And recently I did a detailed review, systematic review on when I was looking at some of the AI tools that are currently being deployed to support patients, both the medium and long term, and what we should expect. At the moment, what I found very impressive was that the high potential for the ones that have been deployed. There was 85 to 99% diagnostic accuracy, 12 to 58% modality reduction from the status quo that we had prior to deploying these tools, and 451% return on investment. Again, for those who have invested in this, as well as hundreds of billions being served by the medical field for countries that have deployed artificial intelligence in their healthcare system. Notwithstanding the limitation at this early stage of 10 to 15% prospective validation, the flaws that exist in methodology, the risks of bias, and I love how Prof spoke earlier on and talked about standard. I was really touched by Prof constantly mentioning standard and capacity building, and the data silos and workflow that's limiting some of these. So it was kind of a paradox. I call it a paradox in the paper that I just published on this. I call it the paradox of value in healthcare AI. And I equally commissioned another study where I had a set of students, medical students, call hospital in the continent, and we equally screen papers. Again, we may not have captured all, but we did speak to all the countries, all the 53 countries in the continent. And our goal was to identify the AI currently being deployed in the healthcare within the continent. And just a few countries, South Africa, Nigeria, Morocco, Ethiopia, Egypt, Ghana, Mauritius, Rwanda, and Kenya, we had identified the AIs that are currently being deployed, with South Africa and Nigeria taking the lead there with 3 from the ones that we identified when we made the call or we checked online. And the clinical domain frequently deployed were infectious disease, radiology, primary care, oncology, telehealth, endocrinology, maternal health, EHR, surgery, cardiology, and multiple components. Again, with infectious disease taking the lead, as we know, is a major issue within the continent. As I look at that, and I was reading the Stanford report this morning, I couldn't stop but thinking, yes, we are at this preliminary stage, Nigeria deploying 3. And when Prof spoke earlier on and talked about standard, I was thinking about what I had found in this report, this Stanford report, where if you go on Google now, or you go in your browser and you search a keyword, you always have something at the top that called AI overview, just the summary of what you're searching, which is an AI giving you the information. And it turned out that from a study that has been done in this Stanford report, that a lot of patients and now doctors rely on the information, or they support themselves with, from this AI overview, where majority of it, 92% of it, was based on common health queries, like does pus mean it is infected? Again, this is for a patient engagement. But there were other questions that have most doctors now relying on AI queries supporting them in their decision making, in their advice, in their diagnosis. There were a lot of questions on symptom queries, 92% of them. For instance, the dementia symptoms, where people are diagnosing themselves using AI. And just the normal AI overview on Google. Treatment queries, dementia treatment, these are just an example, but there were a lot of those. Condition question and queries. What is dementia? We're trying to know more about it. Instead of asking their doctor, people now rely on the AI as the doctor. Conditional queries. So a lot of these classified this way, and not just the patient that were engaging AI, but doctors themselves were using AI to support the information that they were giving to patients. And when I saw this, I decided to look at, again, this was prior to the work that I had done on where we look at avian influenza when it had just come out, to figure out, given that patients are moving towards engaging AI, can AI really give them the right information? And on the right-hand side here is a paper that I recently just published in One Health, where we found out in that result that AI actually gave accurate information comparatively, 82%, 91% in some cases, on avian influenza in the advice. Again, this was benchmarked with information we got from doctors themselves, infectious disease doctors. And then there was a review that was published in NPJ Digital Medicine that talked about the role of agentic artificial intelligence in healthcare. And in this scoping review, when you read it deeply, you realize that most doctors are already building their own agents that keep them up to date, that screened medical literature in real time, and then support the advice they give to the patient. When a patient comes to them, they have their agent, they have their information, but they still query the agent to look at the status quo, the standard, where it is. And most doctors reported that that was helping them a lot, because there are some of the things that they were not up to date, but it was very easy for their AI agent to be able to screen the information and give them in real time. And when I look at that, I started thinking about other risks that could come and play. And I love how Prof talked about standard. And I decided to take the AI solution that we're currently deploying in Africa, in the countries that were deployed. And there's a model to simulate risks, where you can simulate the risks and look at the risks that could emerge. Again, I look at risks in multiple domains. This is still ongoing work that I've done in this direction, where I'm taking every AI deployed in Africa, in any hospital in Africa, and I'm simulating the risks that can spill across the pipeline, right to deployment. And in Nigeria, particularly, the issue of 67% risk on data transparency. Deployment scale was not a major issue. Funding sustainability on new AI. And again, I will speak strongly to this when we start talking about the standard that Prof was talking about. Funding sustainability is a major issue. Clinical domain gap, population equity, 100%. Benchmark gap. So there was a lot of risks within Nigeria and some of the solutions that we had. Again, I'm going to leave out the other one on South Africa, Egypt, and all not. But Rwanda tend to have a minimal risk per se compared to the other countries. They do have a lot of standard in place. And as I look at the standard, the Oxford AI, the Stanford AI report, there was a place there where they were advising doctors to make some declaration once they use AI patient. In particular, the work by Melo and his colleague that was published last year was referenced. They had raised two questions that doctors, at any one moment, if you have to even use AI to support your agentic system, to support you in advising your patient, you should be able to ask two questions. Does the use of this AI tool or inaccuracy in its output, very important, inaccuracy in output, because who is responsible, carry a risk of harm to the patient? First question they need to ask in this framework. I really love the framework they had. And when it is yes, then you require consent from the patient. But at the moment, according to that report, a lot of doctors use it without seeking consent from patient. And again, I still want to call back to Prof what Prof mentioned about the standard. So, which means that AI-guided non-autonomous surgery robot, you need to be able to get the consent if you're using it. And then the second question, if the answer is no, then you move to the second question on that. And the second question asks, does the patient have an opportunity to express agency in response to disclosure of AI use? If the answer is no, well, you can move ahead without disclosing it to the patient that you're using the AI. But if the answer tends to be yes, then you need to inform the patient of the AI use. Again, there's no stigma in saying you use AI to advise your patient, because it's good to declare that. A lot of doctors who do not want to declare that, they want to keep the information to themselves, said not to say come across as they use AI. No, it's a help. You use it to support you. You build your AI agent to be able to screen the literature and support you instead of you having to go over newly published article. And so disclosing that to the patient is very important. Now, if the answer is yes, then you notify the patient. But if no, then no consent or notification is needed. As I think about this, and there's a lot on some of these questions that can be asked, and Prof was talking earlier on about standard, I started asking myself, well, one may say we're lacking behind, but I would say, thank God we just have 3 AI being deployed in healthcare. There may be more, the ones that we discover, before the medical association step on board to say, what are the ethical considerations? Again, Nigeria as a whole may have an ethical framework, or may not. The health may have, but the medical association needs to say, for you to be able to use it, being a doctor, to be able to use AI to advise your patient, for you to be able to use AI in diagnosis, how do we come up with a health AI or medical AI framework? Have we done that? What are the things that need to be considered? Well, I will argue that we need to look at the entire AI pipeline, starting from when we are asking the question as medical doctors. Again, let's say an AI was developed, say in Rwanda, or say in the US, and brought to Nigeria for diagnosis. Very exciting. It may start working very well. The first question that we need to ask was it tested? How long was it tested? Because there's been an issue of an AI working initially, and then in the long run, expanding the biases that exist. But initially, people thought it was working effective. The medical association need to step on board here to say, do we have an ethical framework that starts from even when we bring the AI, when you bring the AI in, we say, wait a minute, before you use it anywhere, let's ask question on the pipeline that was used in creating that AI, starting with the question that motivated the creation. If it was either done locally or not done locally, there should be different questions. From asking questions towards designing and developing the model, towards deploying. And in deploying here, there needs to be several phases that start with it. It's not like I built my AI model, I tested it, and it worked effectively. No, even if you build it with the data in the country, there's a difference between what you do in the lab, just like a wet lab, and what you deploy in the field. There needs to be a long period where you test it and answer several questions that will be put in place. And for these, we then realize, when we start asking this as the medical association, we then realize that every component of the pipeline have a unique question that need to be considered, the ethical question that need to be considered, or ethical challenges that need to be addressed. And that goes round till the post-deployment, the scaling, and the monitoring. Whatever those questions are, I always want to emphasize that they always need to be asked at every stage is it locally relevant at this stage from the pipeline and informed by the community? The tool need not be developed in the country, but even if it is brought in, those questions need to be asked if there is need for recalibration and recalibrated if necessary. Not necessarily keeping it out, but recalibration. There need to be a strong board in place, ethical consideration. Again, I'm glad that Prof was talking about it. Is it responsible and ethical for policy and regulation? And is it explainable to the society, our society? This may be explainable in a different society, but when it comes to Nigeria, our country, it needs to be looked upon differently. All of these need to be asked. Now, even if somebody shows record that this is working, the board needs to set a timeline for testing to see that before you scale it, before you use it at scale, we need to test it for a long time and observe it and keep on asking several questions as we move on. Again, I want to thank the board. I want to thank everyone for the amazing work. I'm looking forward to continuing my engagement with the board to be able to see that we ask all these questions and support the work that Dr. Kakanfo is doing and build a capacity. I really love how Prof emphasized the need for capacity building at this stage. Over.
Wow, it's amazing thoughts from the two professors. Professor Jude Kong, thank you for those insightful thoughts you left, and also the slide and the empowerment that we received from this year's session. I think we can take questions now from the session by both Professor Jude Kong and Professor Oyitokpe. Please drop your questions in the chat. There were some that had come in earlier. We would start with those and then we can take newer questions. I see someone whose their hand is up. We'll just take a few questions in the chat and then we can take one or two people who are ready to speak to the questions. Thank you very much, Professor Jude Kong and Professor Oyitokpe. So there's a question here that says, from Olukemi Akimusure, it says, in as much as we appreciate the speed and sometimes convenience that AI brings, don't you think using guides and machines instead of humans can have negative impact on the human's mental wellness? I think we'll allow the two profs to just take a stab on those 1 minute. Professor Oyitokpe, you can start first, and then Professor Jukong, while I bring up the other questions.
Thank you very much. I think it's a very interesting question. So that is, and it's particularly relevant in medical education, where you don't want your students to rely 100% on AI instead of using their own brains. But at the same time, productivity can be enhanced when people utilize AI in a very, very controlled and ethical way. So it's not a negative thing, it is positive, but it has to be controlled. Thank you.
All right, Professor Jude Kong.
No, thank you. I totally agree that whatever we do, our mental health is very important and everything affects our mental health. Within education now, like Prof was saying earlier on, where Prof mentioned some universities that are already leveraging AI to be able to train their students, we need that to start moving to say, how do we coexist with AI? Again, every technology that we have had from the past, our phone assisted us. They always help us to move from one level to another. At some point, when you use your phone a lot, again, screening on your screen, being on social media affects your mental health. But how do we moderate that at the same time and have that technology help us? And that's that's where now the ethical consideration on that prof and the board will be putting in place, so that you consider all of this and advise the country from a medical perspective when we start using this. It's very, very important.
Thank you very much, Prof. There's another question for you, Prof. Not just yet. I know you need to run off now. The question is around ethics and consent. However, at what point do we seek consent? How do we factor all the logistics into the burden of the existing patient to doctor ratio in Nigeria? What it means is, like, I think what the person is trying to infer is that with the significant burden already on the doctor, at what point can we factor in consent? How can we practically work out the issues around consent? Professor Jude, are you still there?
Yeah, I'm here. No, thank you very much. I love how Prof started his talk by talking about standards. It's very clear that within the continent, AI will really create a huge impact. Why? Also about the point of need. We have fewer doctors. It used to take me around 4 hours trekking to be able to see a family doctor, and there was no specialist there. So it to be sent somewhere. So a lot of people would die on the way. People self-medicate out of that. So with point of need technology where people can sit in their house and get some help, with telehealth, that's going to help the continent a lot. But that doesn't mean that we should accept everything that will harm us. There needs to be regulation. And that's where the medical association come on board now to say, what are the standards before we deploy this? The fact that, yes, we're overwhelmed, doctors are overwhelmed with work. Yes, we need the AI to assist the doctors. Yes, there are communities that are far from the central system and they need the AI. It doesn't mean then we should give something that will harm them. It's still the board responsibility to ensure that we put in the regulations that will control this AI and we use it in an ethical way. It's very important that it's responsible AI used in a very ethical way. I said earlier on about having only 3 AIs being used in healthcare in Nigeria, and I said it may be good because the board is catching up, the association is catching up now. The Nigerian Medical Association now is working on. Prof talk about standards. I was very impressed. Once those standards are in place, other AIs can come in when the standards are already there, because you don't want a plus where the AIs are already all over and there's no way to control it. So it's good that at this stage of starting, the association is already talking about standard. Once the standards are there, the AIs will come, and the good ones will come. They will eliminate the ones that are not good, and the good ones will replace them and be used throughout the whole country.
Absolutely. Thank you very much, Prof. And thank you so much for your time. I know you have a time crunch also to step aside, but we still have Professor Aitope with us. We just take 2 questions by hand. We see Abdul Wahab and Dr. Ladapo Asinyobi. We'll take those 2 questions. Keep your questions short and straight to the point. We'll take Abdul Wahab. Sorry if I'm not calling you with your title. And then we'll take Dr. Ladapo Asinyobi.
Thank you very much. Thank you for this meeting. Hi, Jude. Nice to hear your voice again. One of the things I just thought about, and I know some of these things are already happening here in Toronto, is that we're looking at this AI scribe thing coming in, and where, there's a push by Ontario to allow the family physicians begin to use this because they help, especially with the financial processes, all those documentations that they really need to get the money from the government. Now, looking at that into Nigeria, you said the issue of consent. And I'm asking myself, because consent is important, especially, now that everyone is informed. But the other question is, back in the days when we used to use regular libraries and before we demoed onto Google and all these other different research platforms that we use to get information and articles, we never used to seek consent from the patient to read further on the patient's condition and then come back to improve the treatment protocols. But now, because we're creating an AI agent that's basically getting all that data for us, and then we're still basically going to read that data, reprocess it with our brain as a doctor, and then still now take action in managing the care of the patient. Why do I have to now inform the patient about this when back then when I was using my library and going to library, I wasn't telling the patient, oh, this is your diagnosis, I'm going to go to the library to go and read and come back to you. I don't know if you get me. So
sorry, I get you totally, and I think I support you.
But the AI scribes are going to be a bit different because, the scribe is going to, from the beginning, take that information from the patient directly. So yes, that one, I think we need to put some sort of consent, either pre-clinical or pre the hospital visit before we do that. I would like your comments on that. Thank you very much.
I'm glad it's Prof you're asking, not me. Prof, over to you.
Thank you, my brother, and I'm glad you're in Ontario. We should make some time and catch up, my brother. I want to go back to medical field, the way it was practiced. Again, Prof will correct me here, and Dr. Kakamfo will correct me here. There is no way a patient will come to you and you give them medication without telling them about the side effect of that medication. You need to discuss with them what could go wrong with that medication. And it will be the consent that you're asking that they agree to take on this once they sign. As a doctor, it's a responsibility. If you're having an operation on a patient, you need to give the chances of it going wrong to the patient. Again, some doctors may not practice this, but that's why you have the medical association to enforce some of these. Prof was talking about standard. There's a standard that exists in that practice, and you give the consent. The patient needs to accept that, yes, I accept to undergo this operation, and knowing fully well that you accept the risks. And that's exactly the same thing we're discussing with AI. If you're automating the process, people need to know what could go wrong. They need to know about the risk. So you need to ask for their consent.
Yeah, that's insightful.
So-
From a risk perspective, I think it's important to, Prof, you want to chime in, sir? Go ahead, sir.
Yes, I just want to say that this consent that we are talking about is in various forms. You have implied consent, you have express consent, you have informed consent. So, but when it comes to the issue of AI, like Prof. Jude Kong has actually said, so the patient needs to, there should be transparency in whatever we are doing. So we must not hide anything from the patient. So because the challenge comes when something is hidden from the patient, and then the patient comes to know later that there is information that would have been given to him or her which was not disclosed. So, and I think that it's nothing in this world now. Some patients, I've seen patients that know more than their doctors, when they come, because they are already suffering, having this challenge, and they have read so much about it that even as a doctor, when you are sitting before them, they'll be asking you questions because they've been on it for maybe years and they've seen so many doctors. So they have that knowledge. So if we want to do anything for them, let us ensure that we let them know our limitations. And if we are going to do more, let us, even if we are going to consult others, let us make sure that we know. But the major issue that I have seen is the fact that when you are going to use robots and some other, AI equipment and everything to perform surgery, if it goes wrong and you have not told the patient, who is liable? Who is going to be liable? Can you take the robot to court, for example, and say, this particular surgical operation was not performed by me? But if the patient is very much aware of that, then that is taken care of. But if you are saying that you are the one that is going to do it solely, and at the end of the day, you have used some other things that affected the outcome, and the patient is not aware, I don't think that will be good enough. But the bottom line, the summary, is that we should come up with guidelines, and those guidelines are already there in so many places, but we need to harness it and then make sure that we tailor it to our local needs, in Nigeria.
Absolutely. Amazing. And thank you very much. That was a brilliant question. Our time is running out. We still have one more session, and we still have opportunity to ask more questions later on. But let's take, I know Duke Oboko is also hands off, but I'll take Dr. Asinyobi first. If we still have a little bit of time in this particular round, we'll take Dr. Asinyobi. Please go ahead.
No, don't worry. Let's just go with next discussion.
All right. Thank you very much, Professors Jude Kong and Professor Itope. It's a privilege to have you, Professor Jude Kong. I know how much we struggled for this session. I missed your session in the parliament. I wonder where you're sitting right now, but this is really well appreciated. I'll look for you this evening, hopefully. Professor Itope, you're still with us, and we'll be glad to still have you to help us answer more questions as we go on. So we'll take a further deep dive into some of the perspective around, like more like a 360 degree perspective, from the perspective of the user, of the tools, and also from the perspective of what we need to do in terms of positioning. So I will be taking this session, and the goal is not necessarily built in the expertise that we have within the organization that I lead. And I funded Artificial Intelligence for Social Impact and Development, and also the managing partner for the Africa Hub for Innovation and Development. So one of the things we do is to catalyze this kind of conversations and the need for change, for framework, for guidance under our AI policy work, and also we drive a lot of talent and development and capacity building, and also we do solutions development. We have on the call artificial intelligence team. I don't know if Dr. Wale is here, who is also a medical doctor and also has got a master's in AI and data science. He leads our AI engineering team within our organization. But if Wale is here, please let me know so that he also wanted to say a few things. But otherwise, we just go on. And I think this conversation is important because looking at where we are right now as a country, the realities are that the healthcare market is literally been hijacked from those of us who work within and has the domain expertise for healthcare. And that's, for me, concerning. There are a lot of realities that shape the healthcare market in terms of AI in healthcare. The Nigerian AI in healthcare market is projected to be about $130 million, of course, significantly above the budget of the Ministry of Health. And what is key here is that this comes pretty much from from persons who spend on their healthcare. Out of pocket spending, the cost is usually defrayed to the people who spend, the people within the population that we treat every time. And it's important to know that a lot of investment, whether we like it or not, are coming into this space to be able to drive the spending around AI. There are AI innovators that we have even on this call. We have an AI accelerator program within our organization. We're training 30 innovators. Dr. Wad, I've seen him on this call. He has an innovation in health, and a number of them, and this set of innovators are gathering investment from private equity investors all around the world, and all of these are coming into the Nigeria healthcare ecosystem, whether we like it or not. So there's a big promise, there's a big opportunity that we're missing, even if it looks like a lot of us are pretty much faced, in the clinical direction. On a global scale, you realize that even the AI in health market itself is really large. We're talking about billions, and for those of us who are very familiar with AI, you know that the investment in AI alone, it's enough indication to know that we cannot do business the same way. Nvidia alone has invested over $1.3 trillion in AI. The American government had invested much more than that as a government. Of course, the UK government, Chinese government. That investment is already shaped the way the economies are being perceived. As you all know, even wars are being perpetrated right now with AI. I'm sure many of us must have heard of MITRE. MITRE was to be used against the war in Iraq, in Iran, and then is now in quotes being released into the system by Anthropic in a very interesting way. So the AI evolution is very significant and very real. We can't do business the same way anymore. As a country, in Nigeria as a country, we are also growing, but the growth is happening mostly in the private equity space. It's happening mostly in the infrastructure space. The AI is being integrated into the tools that we're using. We have the AI handheld ultrasound scan. We have the AI robots doing surgeries in some cases. Those are trickling in and are taking over that market. But the interesting bit is that we have no control over it. Clinicians, doctors, most of us who are playing in the healthcare system have no control over it. And if you look at where the money is going, the money is essentially going, to medical imaging. You have these days when you have an X-ray, an AI system can read the X-ray. That's one of the projects Dr. Ali had worked on. You can just put an X-ray and take a picture of the X-ray or put it within the AI machine, and the AI, instead of a radiologist, the AI system can read it, and then of course the radiologist can look at it later on. But also look at the different places that it's going into. Robot assisted surgery, particularly on a global scale, drug discovery. One of the things that we're seeing much more now is virtual assistants and chatbots used in the healthcare system, or used by patients, and those patients are using these chatbots because we know one of the popular ones, you think it's Our Doc or something like that, by a Proco doctor and his team. Those are places where this investment and these monies are going into, and of course you can see from our own country, the landscape is that these monies are coming from the household wallet. They're coming from the patient because we're still driven by out-of-pocket payment for our healthcare. So it's important to know that as much as we also play within the space, we need to understand what the landscape is looking like and what are the potential impact for us, as clinicians, as people who work in the healthcare space. There's a lot of opportunities that we could drive in terms of how we change things in AI. There are studies that have been done across global north that shows that doctors are now having more time to attend to their patient because AI is taking away a lot of administrative tasks. AI is becoming the leverage that doctors are using. Just yesterday, for those of you who follow AI news, ChatGPT released what is called AI for Clinicians. ChatGPT for Clinicians is provided free to all doctors that are certified in the US. Just yesterday. And before then, there have been different versions of the large language models that have been targeted healthcare. There's what is called a healthcare benchmark that was released by OpenAI, and also the several Anthropic and all that. They all have their own AI platform, large language models targeted at doctors. That means that doctors can use them, work faster, or take away some administrative pieces of stuff and be able to face more things, either do research or so. There's a 48% better productivity, access to more time that have been documented by Doximity research for doctors, in the global south to be able to have done. And for me, I think we cannot reverse what we face in terms of, the whole JAPA syndrome. But with about 4,000 doctors that have exceeded our system in the last couple years within Nigeria, and of course across Africa, as it were, it is important to know that with AI, there's a lot of tax shifting that can be done. with AI, there's a lot of softening of that load that can be done. So AI is no longer a luxury to us in the Nigerian healthcare or medical practice. There's a projection also by one of the research by the World Future Health Africa group that says that about 1 million Africans can better their lives in 2030 if there's a proper deployment of AI. And why is it important for us right now for us to take this conversation really serious? One of the very, very interesting ways that we can solve our increased workload burden issue within Nigeria with the workforce crisis that we're facing is to be able to leverage AI deliberately and to full scale. So AI is probably one of the affordable response that we can use to solve that problem with tax shifting, with reducing workload, with being able to triage effectively with AI and all that. And because also procurement standards are not in place, so we are literally being driven by AI that are developed on a foreign soil or foreign scale. There's a lot of AI development. Like I did told you right now, there's ChatGPT for clinicians, and whether we like it or not, it's going to come into Africa. Africa is accessible to anyone who wants to use it. So whether we like it or not, the algorithms are being built and the tools are being made available and are being marketed heavily to us from India, China, and all across different countries in the global north. But it's important to know that we need to begin to get sensitized to these things. Whether it's going to be NAFDAC, whether it's going to be MDCN, someone needs to take responsibility. And it's important to start having this conversation right now. It's more like, it's flowing through foreign capital and flowing back into foreign capital in extractive ways through innovations, as we call it. So what do we need to do differently? There are clinicians who are already adopting AI. And one of the things I just want to go through in the next few slides is what is the profile of clinicians and researchers and innovation that are currently adopting AI. It's a lot of data that were put together and it's been documented. Of course, these data are not necessarily from Nigeria, but the sources are definitely on the slide. The Doximity report, which is one of the most quoted AI study in medicine, said that the cognitively intensive specialization like neurology and all that, they embrace AI more. And even in Nigeria, a study by Adigwe says that physicians among the healthcare workforce have been seen to adopt AI more or have better AI knowledge than the rest of the healthcare system. And in terms of innovators and everyday use of AI, there's also another study that says that once a clinician starts to use AI, they tend to use it better and they tend to use it more consistently and they get better efficiency at it. There's another study that put it, but the thing about this is that the hard part is crossing between being a non-user to an effective or an heavy user, as it were, whether it's through the LLMs, whether it's through the triage systems, whether it's through drug discovery or access to commodity, or through hospital resource management, whatever way that you could find AI useful. And this is another data about making sure that we're able to look at what those who use AI for subsistence purposes and those who use AI for transformative purpose, in terms of the difference that you see in their clinical decision making and how AI has been able to help and what the gains of AI are within these two. There's another study also in terms of clinical practice growth for AI adoption. And I'm just putting this context so that we can see that there's a lot being done with AI. And for those of you who can take the screenshot, please don't ask me to share the slides. Prof already quoted this in terms of FDA cleared AI and machine learning enabled medical devices. See how the trend. Hello, please, can we manage the mics, please? The number of tools that are being cleared, AI tools, AI enabled devices that are being cleared, shows how much it's being done or can be done with AI. What you find is that in our own context, through the OEMs, the big equipment manufacturers, radiology has seemed to have captured a whole lot more within the African-Nigerian context in terms of introducing AI into our clinical care or our care. And this one, I think about the last few charts, shows AI adoption in health facilities across the US over time, and you see how it's peaking, and also the use of AI based on hospital size. So some of these things just help us to see, what is possible. Some of the things that, comes really clear and visible from here is that tertiary hospitals would be likely to be able to use AI better in a structured way and have more gains from the use of AI than the small hospitals, because of sometimes the investment, the processes that needs to go into it. And I'll just keep, some of these and then go straight into some of the conversations that really could help us in terms of how we'll be using AI. Okay, so just this last two slides, and this looks like what are the current AI tasks in clinical practice that clinicians all around the world are using AI for. One of the biggest one is medical research, literature search, translation services, making discharge summaries or doing assistive diagnosis and surgical simulations, voice documentation where you could clock your clients, and also there's a device, there's an AI that takes this and also able to transcribe and give you a medical ICD approved format. And what are the key things that even preventing some of our healthcare providers from this is from a whole number of studies. And one of the biggest things that really prevent clinicians, the medical practitioners, to embrace and adopt AI would be the AI, the training, the required training. And that's one of the reasons why we started these conversations with NME and the other groups. Doctors are said to say they want more training, they want more capacity building, and that's one of the biggest stumbling block and limitation. And there's whole lot of things, regulatory concern and uncertainty, lack of formal training, concern about dehumanizing, healthcare and all that. And some of these studies are from even Nigeria, our country, in form of the research work that have been done. But it's important to know that what can AI even do within our space, within clinical care, within healthcare standards. And we have this taxonomy, interesting taxonomy that we developed, and we wanted to at least make you know what AI can do. Clinical diagnosis, medical imaging, treatment planning and precision medicine, in primary healthcare and community medicine, medical education. I think Prof talked a lot about that. Non-communicable disease management, laboratory medicine, regulatory compliance and medical standards, even the MDCN should be using AI, patient safety and clinical quality audits, a whole lot of things that AI can do within our space. And I will not take time on the details of this. They are quite detailed in terms of these domains that we can use AI and how we can use them. One of the things we do with this taxonomy, and if you come into our AI hub in Abuja, you will see the taxonomy is right there. You can come and visit and talk to some of the people who lead our AI work there. In radiology, there's specific things that you can use AI to do. We have in our own solution an AI cough analyzer where you cough and then you take the cough sounds. Using the cough sound spectrogram, you can definitely know the kind of cough that it is with trained cough data. And of course, you do this, using different models. And this taxonomy does have what models can you use what AI models can you use. And I think that's one of the knowledge gap that we see with clinicians and doctors, not understanding the basic AI models and what the AI models can do. And we're not asking every doctor or every clinician to do that or go know that, but it's important to just have an idea and be able to apply your domain expertise appropriately and be able to guide innovations within healthcare. There's a whole lot that is possible or can be done with ultrasound, ophthalmology, and dermatology. By taking a picture, of skin lesion, you are able to make classification of what kind of lesion that it is using few-shot learning, computer vision as those AI models underlining it. So for treatment planning too, it does exist depending on the area of treatment that you're looking at, and you can see definitely the AI models. And these are empirically, proven pathways within this taxonomy where you see AI, becomes relevant in healthcare. And I will really not want to take time to go over all of them because of our time, and so that we can really take your questions and engage and discuss much more. But what is important is that within primary healthcare, there's a whole lot that AI is currently doing. There's a whole lot that AI can do, from decision support for community extension workers to patient engagement using AI, natural language, processing chatbots, and to resource planning and all that. Some of them we are already doing, some of them a lot of innovators within the space are already grappling with and working with. The question is, when they come to the healthcare facility to deploy those things, do the doctors, do the nurses, do the medical practitioners even understand what is involved and all that? So medical education, Prof talked about that. Patient safety and clinical quality. AI is being used in a lot of ways, and these are some of the models that underline or underpin what AI can do within those. I'll just keep some of the slides within the taxonomy. AI is available to most of us, so even if you don't get the slides, you can just check with one of the AI platforms and an area that you're interested in. But this is really common, and that's why I'll focus a little bit about this, how major large language models are being positioned to support medical practice and what this means for Africa, Nigeria, and also low and middle income context. And when I talk about local large language models, I mean ChatGPT, Claude, Gemini, Copilot, and the rest of them. And it's important to know that it's documented, but that about 94% of physicians now use AI, use one of those large language models. In Nigeria, there's still ongoing research and documentation to know how physicians are using large language models, and the physician adoption is faster even than most users of AI for those who have gotten into it. But what is key is that there are different tiers and different ways that these large language models can be used. They can use them as frontier general purpose large language models. Whether you have like a healthcare product, Google already has open source, what they call MedJama or MedLM. Anthropic has Cloud for Healthcare, and OpenAI has, and all of these are accessible by everyone. So it's important to have this understanding so that we are able to navigate how it's used. Then there are specialized clinical AI built models that are also can be used, like Open Evidence is basically only used for physicians. And there's a number of them, Doximity GPT and all that. They are basically clinically developed large language models. It's not going to give you any other information. It's going to give you deep clinical information to support, as clinical decision making or support client care. And then there are a number of all these models also that are open source. That means they are free. You can deploy them, or you can work with, AI engineers and scientists and all that to deploy and use them. In terms of their capabilities and what they do, all of these different large language models have what they can do well. Many of them are EPA grade tools. EPA is the certifying body in the US that certify the use of data in healthcare, and they are EPA grade, and a number of them are not open source. What it means, apart from DeepSeek and MedJama, what it means that some of them needs to be paid for, and the best context with which they are used and what can be used for in terms of the best fit. And I'm just trying to make sure that in terms of what the evidence is saying, there are documented efficiency gains in the use of some of these tools in terms of patient follow-up automation, a number of documentation around how that has been done to and automated in terms of how patient is followed up. Burnout reduction also has been documented as one of the gains. Clinical data processing, following the right data processing rules, reviewing your charts, doing your mortality review, your chart reviews. There's documented evidence in terms of how efficiency gains is achieved 61% in chart review time. And then also admin workload. And I think admin workload is a low-hanging fruit. Scripting, documenting is a low-hanging fruit within that space. And why is it important for us to approach these strategically as medical doctors, people within the healthcare space? It's important to know that we can get we don't have like enough specialists and clinical care, so we can use AI as an amplifier or a multiplier for the kind of work that we do. African clinicians can now take some of these tools and work with data people, engineers, and be able to build that what is contextual and relevant to them. Our patients, like Prof said, are adopting faster than we are adopting. So it's time for us to, really position effectively within this wave. And I'm sorry I'm rushing this, but there are a number of gaps also that do exist in terms of that the LLMs have not been able to close. There's the validation gap in terms of no commercially validated LLMs for our region, for Nigeria or for most of Africa. There's also the language gap. It's something that we're battling with. There's some work we're trying to do, but because some of these large language models are basically built out of English, but there's a lot that is going on. There's an atlas that's able to do, some local language. There's also a lot of other tools that's also able to do some, local language and scripting and all that. There's other ones that are commercially available, like Yarn GPT. They can give you text to speech or speech to text in local language, Yoruba, Igbo, and Hausa. It's just the premium that is being placed on some of those. And also there's the data sovereignty gap or the data question that is still unanswered. And there's quite a lot of risk also that we need to look at. There's the cybersecurity burden on the data of our patients. There's a bias question. If we just take most of those models that are coming, they have a tendency to underrepresent, our kind of population. Then there's also a regulatory ambiguity that we're dealing with right now. The existing frameworks that we have do not sufficiently respond to the complexity of using AI in healthcare in Nigeria and also across the continent. So it's important that we begin to address some of this regulatory ambiguity as we go on, and a couple of other risks that I'm not able to touch on. And what's the implication for us in terms of medical practice and standards in Nigeria? It's important to know that NMA begin to position in terms of articulating guidance and capacity building, and also leading that charge, having a position paper to say this is what our position is on the safe use of AI in healthcare, and not waiting to where there are obvious risks to the patient or the market becomes speculated by substandard AI and all that. And then MDCN, we're looking up to MDCN, NAFDAC, whatever authority or Ministry of Health to be able to help. And our work is probably also to work with government to see how this ethics framework can be catalyzed and put in place. There's the national data protection that is already done quite a lot in terms of healthcare, but there's still a lot much more in terms of having what is like a joint task force. And it's important that if not, then we're going to be stuck in regulatory fragmentation. Who do you go to? Countries have done it differently, and I wish I could show us what countries are doing in terms of regulation, but because of time and because I'd like to really stop soon. But in terms of looking at what countries are doing for ethics, compliance and regulation, what is the pathway to innovation? How do they select vendors and accreditation and standards? And how do we make sure that algorithmic bias and patients are protected? Algorithmic bias is limited or reduced, and how do we make sure redress and liability is taken care of? And if you look at a couple of these countries that we're comparing against, from South Africa to Kenya and all that, realize that we in Nigeria, there's still no coordinated body yet. Even if most of the other African countries are still juggling with a few African countries that have some level of coordination within the AI in health frameworks that they have, or their AI strategy is sufficiently addressed those. But our own AI strategy, even if it addresses all the important things, hasn't gone deep dive into what the implication it is going to be for in health. In terms of data protection law, we have a very, very strong one. I think most of Africa does have very strong data protection laws. It's about enforcement and implementation of those laws. AI specific frameworks not in place in most cases. There's a medical AI device pathway. Now, there's two different school of thought. Some people are saying for every AI that you bring, you consider it as a medical device, and then you classify it into different tiers. There's a global tiering of AI innovations or AI in healthcare application, whether it's going to be a medical device. When you bring a chatbot, how do you tier it? It depends on the use case of that chatbot. And when you bring any other AI tool, maybe you bring a cough analyzer, an AI-powered cough analyzer, or an AI-powered cervical cancer screening tool, like we do use. How do you tier? How do you classify them? And what's the pathway to allowing these things to be used within the system? And I think South Africa had done it well. They had coupled it with their medical device pathway to say when they come, you go through their NAFDAC that screens drugs and medical devices. And interestingly, we're still using NAFDAC for the medical device bit, and in as much as it's just supposed to be drug and food, but we still use NAFDAC for most of the medical device, certification and integration. But also, there's a lot of call for us as Nigerian, practitioners, as Africans, to clearly define. There's some work that already started on that innovation pathway, by the Ministry of Health, but things are still a bit, in the early stages and still very, I don't want to use the word slow, but if you compare with other countries in the global south, you see there's a lot of progress. For example, in Singapore, there's significant progress that have been achieved in terms of best practice for integrating AI in health, and you can look at all those other countries, and China and India is also coming up in terms of ethics around AI and health. But let's just keep to what we really need to do as a country. What do we need to do in terms of ethics? NMA would encourage to issue in the nearest time, either NMA or midwives association or any group responsible should be able to have a position paper on a clinical AI use position. What's our position on the clinical AI use? And I think most other countries or geographies or entities have had to do that before they got to where they are. Establish AI literacy, CME courses or credit pathways, and also engage we're happy to broker those engagement with NDPC, NAFDAC, MDC, and NIDA on what's the way forward, what's the pathway to this, and then also encouraging MDC, and also in terms of what is possible. Why we're doing this, or why we're saying this, is that there's a critical window that we have right now to be able to shape how AI in health will be driven ourselves in terms of locally led by us, and that window is still open but might be closing. The Nigerian healthcare actors can shape its own health standards, or we just simply inherit the foreign ones. So it's a matter of what do we need to do differently. And I just think this is where I will stop and say thank you very much for listening to me. We're still taking questions, and we're happy to engage more for the next few minutes before we wrap up. Thank you very much for the time, and we would take a few more questions, and then we would start to wrap up. Thank you. I'll just go to the chat first. If there are questions already in the chat, we can take them. Seem to be quite a number of questions in the chat. All right, so I'm sure Prof is still here, so I'm not going to be answering these questions alone. So if there are any questions, we're happy to take them. But I'm sorry I have to rush through.
But I have to leave very...
Yeah, Prof,
yes, but I will have to leave in the next 5 minutes.
Okay, so I think we also should be wrapping up in about 7 minutes thereabout. And thank you for everyone who has stayed with us to this time. All right, so
okay,
let's take a few more questions. I see some hand up. I think Duke Ogboko is still back with questions, and I think Emmanuel Adebumi. All right, so I would look at questions in the chat first. And thank you, Elizabeth from our team, responding to some of these questions. There's a question: how visible is it to have an AI software like ChatGPT and Gemini, but mainly for medical diagnosis and treatment in Nigeria? Farouk Aleges asking that, and that's exactly what I said. There's a ChatGPT for doctors. It's not the general ChatGPT. Yesterday, it was like famously announced. There was the one for clinicians specifically. It's ChatGPT for clinicians, and it's made available free for most clinicians. I think most clinicians in the US. I'm sure it will get to Africa soon. I know the way these things move, but there is also the AI that's targeted for the healthcare sector. So you can research and look for it. There are existing LLMs specifically for medical diagnostics. So you don't have to use the general LLM if you really want to get your hands on how to use large language models. And Prof, please feel free to chime in, sir. If you want.
Yes, I just want to say that we should not be 100% reliant on what is coming from the West. And that is what you have mentioned, that in terms of language and everything, there are gaps. And we within our own limitations, can come up with what is really very appropriate for us. So one of the challenges is that we have been using data from every other place, but not within our own countries. And I think in Africa, we must begin to look at, locally produced and locally relevant, software, that we can use. So yes, it can be made available to us, but we can also, develop our own.
Absolutely. Thank you very much, Prof. So we'll take questions from Duke Ogboko and Emmanuel Adebomi, and then we can wrap up. If you have questions, drop them in the chat. If you have any follow-on questions, I'm happy to leave my email for any follow-on questions. The recordings will be made available, and also the report of this session would also be made available. And Dr. Hamid, if you're there, and we have the NMA leadership back, we're also happy to take those closing remarks soon. All right, Dr. Suraya, I see you. Go ahead, sir.
Is my voice audible now?
Yeah, we can hear you now.
Okay, thank you. Good afternoon or good evening to you there. Actually, mine is not a question, rather it's like a contribution, because I so much appreciate what all that the professor has been saying, and also the young man from the University of, is it Toronto or Ontario or something like that?
Toronto, yeah.
I enjoyed that, and the last thing you just mentioned. But what came to my mind, because yesterday I was discussing something similar with Micro One, because I belong to that group, the Certified Micro. And most of the discussion was centered around governance structure in most of our African countries. The governance structures are there from the highest to the lowest level. They're from national to the LGA level. Now, what are the things who are those people that work within the governance structure? They are the medical doctors, clinicians at the top. They have healthcare workers below them. But they are all contributing one thing or the other to make the success of a healthy living of a patient. So my own contribution is that capacity development of that governance structure is very important, so that the ethical things like the professor mentioned can be observed. Because if you are not too experienced in the clinical field, and ChatGPT or whatever Canvas or Gemini you are using, it gives you an answer, and that may not be the ultimate, because you need to be experienced to mix your experience with that. Because the other one, the human intelligence, which is from you. So you need to, so that is to say, the capacity of everybody should be built, but essentially, those are the lower level, so that they can complement the effort of the clinicians that are at the top level, really getting the patient management rate and putting the patient at a better healthcare services in the country. So what I'm invariably saying, the governance structure has to be really done, and there should be a roadmap. That roadmap would have brought so many things that we think of what we can absorb for the meantime, not doing everything at the same time. The roadmap will tell us what we can start with, what should be the medium term, what could be long term, because we will attempt to swallow up, then we'll come up and end up bringing technology that we may not be able to sustain. At the end, we'll be going back to the same level again. Thank you, Dr.
Thank you very much, sir. Thank you for those insightful comments. A roadmap is critical in terms of navigating the AI in healthcare trajectory. And I think that's needless to say that one of the things that these sessions do is the literacy and the awareness of these things. And I know there are people in government we're already interfacing with. They have interest. We had a national workshop on AI in health where Ministry of Health took some significant leadership, and all the MDAs in health also attended. So there's already work going on in the background, conversation going on at different quarters, and with the National Association of AI Practitioners now that we now know about through Prof, we will definitely engage more to drive some of these significant outcomes. Thank you very much for that. Then also mention that we have a drop-in AI in health masterclass for those who want to go on deeper. And I see a number of people on this call who I consider as experts already. So like I said, we couldn't introduce and acknowledge everybody. I'm sure if I call some names, they'll be like, "Oh, he just called me out." But as much as possible, let's bring forces together. So I did had a conversation with our team earlier on today. We have a very small group of people we have trained in AI in health. When we did the first, groundbreaking capacity building workshop, and we're in a small group, like a small community of practice. So we're hoping that we can expand that community of practice. So we said we can start it with a WhatsApp group and begin to recreate that conversation around what is necessary. We share information, emerging trends, what's going on, tools and all that. So we can get started with that. That's in our own plans. Our team is able to drop the link, the WhatsApp link, for people who want to be part of those conversations of the community of practice in the chat. Just a group of people that do not know but want to do something, want to see better outcomes, want to see shaped trajectory for AI in health, and see that framework we talk about. So we'll then begin to have conversations where we can frame things. So we can just, because we already have that small group, I think about 50 people. So we're expanding it now to, doctors, nurses, healthcare practitioners generally, just a community of practice where we share and learn. So please feel free to join, and then we can take conversations on from there. Emmanuel Adebomi, Prof, if you want to say anything, sir, please chime in.
Okay, thank you so much, sir, for the opportunity to ask this question. Sir, I just want to ask, for now, if there is an innovation that one has in healthcare system, maybe like AI automation in healthcare system, who are the bodies that one can still go through now to have that probably registered and probably make it recognized? Do we just go ahead, deploy the service? And also, is there any way in which the present LLM we have, we can incorporate our community specific or probably tropical specific data? Because most of these informations that we have, and this I'm bringing out because of the issue, the problem that this might cause for the patients that probably have access to LLM, they can ask, but there are prompts that they give and there are answers they will get that are not actually specific to our locations. And most of the time, this actually creates a lot of issues, probably during consultations, because they have asked AI has given them a diagnosis, has given them different things, and then they view it differently. How do we regulate the information that we have on this our present LLM that will be so specific and probably tailored to the need and the tropical medicine that we practice? Thank you so much, sir.
Yeah, so I think you're bringing the question that we are all trying to answer back to us. Obviously, that's a big gap in terms of the foundational models that are used to build these LLMs. There's still a lot of gaps. I did a course on ethics, AI ethics, with the University of Cape Town. One of the things that was very clear is that Africa still has a lot of gaps in terms of our setting, our context, the algorithms that are used, the information that is used. It's going to definitely increase the marginalization that we do have and see. So this session is also a call for us to get involved, for every one of us to get involved. Nigeria would need, more resources, more engagement, people who are working on this, frontier models, even if it's using the already existing, models that we have, the free frontier models that we have, and kind of, tuning them or refining them to our context, or feeding them or training them with more data. We need to start from somewhere. We need to start doing something. So there's a whole lot that can be done or should be done, and I'm not sure this session can answer the whole lot that should be done or can be done. And what is key is that we continue the engagement and we sustain the engagement. We have relationships with NIDA, with Nigerian Center for AI and Robotics. You can reach out to us. We can make those connections. But if you have an innovation, the pathway, on a legal standpoint or formal standpoint, the pathway is still being worked out. But because everybody is jumping into the industry following the digital transformation wave that had happened, so there's a startup act need that you can key into, go through the startup process. And also there's a number of other processes that you have to go through, but they are mostly anecdotal. There's no guidance that say this is step 1, step 2, step 3. That pathway, I'm sure the ministry already started the conversation. I was invited to speak at the inaugural session of it, where they're discussing the AI innovation pathway, not AI now, digital innovation pathway. We have not even added AI yet. So I think you just need to keep getting, reaching out for advice and all that. And I think it's only a matter of time. We will be able to frame these things. We need to close soon, so that people can get on with their days. And I just want to start wrapping up.
Okay, so I'm not sure if you've been able to hear me. I've been trying to. Can you hear
sorry.
me?
I'm sorry.
Yes. Okay. So essentially, first of all, permit me to, on behalf of the Nigerian Medical Association, thank you very much for the innovation and particularly for extending this partnership to the Nigerian Medical Association. This is why we're here, but most importantly, and permit me to start to also extend sincere apologies of the Nigerian Medical Association President, Professor Bala Mohammed Audu. He's away for the World Medical Association Congress, and as you may be aware, we're preparing for transition next week. So a number of the other the vice president especially, is still neck deep in some of the preparatory activities, and so that's why they were not able to join. Now that brings me to the point I'm trying to make, which is the fact that the Doctors Medical Aid Foundation was established by the Nigerian Medical Association to bridge this gap, such that away from the politics, away from the professional agitations and all of that, we can have these conversations going, and which is why I lead this team, and we're open. I've been quite impressed by all the conversations, the questions, the contributions, the gaps that have been highlighted so far, and I'm by this expressing our commitment to continue to partner. That's what we have always wanted to be, provide the technical partnership required to improve the Nigerian health sector. And in this particular case, the AI in health is a gap that we've identified, that we're committed to, and that's why we're able to. We had partnered with your team to ensure that this is a success, and I'm glad that it's been so far so good. So please, let's keep the conversation going, and you can be assured of the Nigerian Medical Association through the Doctors Medical Aid Foundation to provide any, and I can't say any support that would be required. I'm sure this is just the beginning of the partnership that works and would not be the end. Thank you once again, and very big thank you to all our speakers, the keynote speakers, and all participants for being here. Thank you so much, and I hope you do enjoy the rest of your day. Back to you, Dr. Kakanfo.
Thank you so much, everyone. I really just want to say thank you to the Nigerian Medical Association. Thank you, Dr. Amit, who leads the ICT and also the country director for the Nigeria Medical Association, Nigerian Medical Aid Foundation, sorry. And also say thank you very much to Professor Eyitope Ogunbodede, the former Vice Chancellor of the Obafemi Awolowo University, and also the National President of the National Artificial Intelligence Practitioners Association, which is a very, very loaded association. If you want to continue the conversation, please feel free to connect with me personally on LinkedIn. Join the AI in Health Community of Practice WhatsApp group. We'll engage, and we're also engaging more with the National Association of AI Practitioners through Prof. In the coming days, we'll be able to do much more. Like I mentioned, we have drop-in sessions for AI in Health Masterclass. If you want to join the waiting list, watch out for that on LinkedIn. Or you can even have the link on the chat to join the waiting list. If you want to go deeper in AI in health and have an all-round framing of it. And thank you very much, everyone, for joining, and have a good rest of the evening. Bye.